A very good afternoon to all and a very warm welcome to the ISA online PG classes. These classes are held every Monday evening at 6:30 p.m. and I feel very happy to announce that this is the 99th session of the ISA online PG classes, which started in July 2021. Now, these classes have been very well received. Classes was an initiative of the ISA leadership, and it has been very well received by the postgraduate because uh, there are teachers of repute from all over the country who spare their valuable time and effort in order to help the students of the country, in fact. And today is no different. Today we have two very eminent teachers from Midnapur Medical College, Dr. Suman Chattopadhyay sir and Dr. Debashish Bhar. But before we introduce the speakers and the topic, as is customary, we will try and invoke the blessings of Ma Saraswati. So,
Saraswati Namastubhyam Varade Kamarupini Vidyarambham Karishyami Siddhir Bhavatu Me Sada.
So to coordinate the session today, we have young faculty, Dr. Derlin Thomas. She is an associate professor in the Amla Institute of Medical Sciences, Thrissur. And I'd request Dr. Derlin to please carry forward the session from here.
Thank you, sir, for those kind words. Now I'll share the screen, sir. So 1 second.
Yeah.
Is it visible, sir?
Yeah.
So a very good evening to you all. So today in this brainstorming session on how to tackle short cases for improving your result in the practical exams, we have here two eminent senior faculties, Professor Dr. Suman Chattopadhyay sir, as well as Dr. Debashish Bhar sir. So we are very happy and proud to have you here in this session, sirs. So first of all, I welcome Professor. 1 second. First of all, I welcome Professor Dr. Suman Chattopadhyay sir. He's a professor and the head of the anesthesiology department of Midnapur Medical College, West Bengal. And sir is at the medical education unit as well as the skill lab coordinator in his college. He is also an eminent member of the institutional ethics committee. He is an elected member of the National Academy of Medical Sciences, New Delhi, with a fellowship in pain medicine by Indian Society for the Study of Pain. He has got around 6 book contributions, including editorship, with over 45 journal publications to his credit. And he is also a reviewer of many journals. And his main area of interest is in anesthesia in resource-limited scenarios, as well as in the applied medical education technique. We welcome you here in this session, sir.
Thank you.
Another important faculty of this session is Dr. Debashish Bhar sir. He is an associate professor from the Midnapur Medical College, West Bengal. He has around 5 international journal publications with 7 national publications, and he is also a reviewer of various journals. His main area of interest is in critical care medicines. So we are so excited and proud to have both of you here in this session to moderate this. Over to you, sir.
Thank you, sir. Thank you.
Thank you.
Sir, if you could just introduce the students of your college who will be presenting.
Yeah, the first topic is tonsillectomy, and it will be presented by Dr. Trisha Biswas. She is a second-year student of Midnapur Medical College, MD Anesthesiology. And the second case will be presented by Dr. Anushree Pal. She is also a second-year student of MD Anesthesiology, Midnapur Medical College, and her case will be postponed contracture. These are the 2 cases, short cases, which we have for today from Midnapur Medical College. Dr. Trisha, can you just start your slide?
Yes, sir.
With your kind permission, can we start the session?
Yes, sir, absolutely.
Okay, Trisha, please start.
Good evening, respected teachers. I am Dr. Tisha Disha, second year at PGT, Department of Anesthesiology, Midnapur Medical College and Hospital. Today, I will be presenting a case on a pediatric patient posted for tonsillectomy. Patient's name is Sheikh Shaidul. He is 8 years old male patient. Informant was he himself and his mother. They resided in Kharagpur, West Midnapur. Patient came to ENT OPD with stiff complaints of pain in throat and difficulty in swallowing of food since 12 days, along with reduced food intake since 10 days. I come to history of recent illness. Patient had throat pain, which was gradually progressive, aggravated on taking cold liquids, relieved on taking medications, and warm fluids. There was history of throat rot, 8 episodes in the past year, which was associated with fever. There was history of recurrent upper respiratory infection from childhood. No history of recent onset respiratory infection or any respiratory distress or any fever. There was no history of any ear discharge or rhinorrhea, no history of any mouth bleeding or snoring, and no history of any sleep disturbances.
Okay, Dr. Trisha. Now, this patient has upper respiratory tract had upper respiratory tract infection or lower respiratory tract infections. And previous history.
Based on the history, patient had upper respiratory infection.
I didn't get you. You are not very audible clearly.
This patient, based on the history, patient had upper respiratory infection because it was associated with fever along with sore throat, which is a feature of upper respiratory infection.
And if there is a, when do you suspect that it is a lower respiratory infection?
When the patient will have respiratory distress along with wheezing, then we'll suspect that the patient has lower respiratory infection like pneumonia and any expiratory fluid.
Why did you ask the patient regarding snoring?
Because this patient, in case of chronic pancreatitis tonsillitis or in case of adenoid hypertrophy, this patient will present with snoring and sleep disturbances due to obstruction in the airway that can be partial or complete.
So these patients may be a chance for obstructive sleep apnea. So any sort of other history are you going to take in these patients?
For this, if we suspect obstructive sleep apnea, we'll ask for either a cold score or the STBR questionnaire, which is snoring, trouble breathing, and feeling unrefreshed after the night sleep.
Okay. So obviously the patient did not complain of snoring, so you did not ask these things.
Yes.
So what are the signs that the patient may have along with this adenoid hypertrophy?
Patient will complain of postnasal breath, signs of rhinosinusitis and rhinitis, and patient will have features of airway obstruction like mouth breathing, snoring, and sleep disturbances.
Okay. So this patient did not have these features.
No, sir.
Okay. Move on with your exam.
I come to history of past years. There was no such past medical and surgical history, no history of any bleeding disorders. Antenatal history and birth history were non-significant. Immunization history were up to date. Developmental milestones were normal. Family history was non-significant, and there was no allergic history. I come to general examination. Patient was alert, conscious, and cooperative. Patient was playful. There was no history of any difficulty or shortness of breath during play or any outdoor activity. Patient's weight was 35 kg. There was no pallor. BP was 110 by 68 millimeters of mercury. Pulse rate was 84 per minute, regular and normal for me. Patient had respiratory rate of 16 breaths per minute. And on lymph node examination, there was tender and enlarged upper cervical lymph nodes.
Okay, Dr. Trisha, I have a question for you. So if there is a sort of respiratory distress in child, what are the clinical features of those respiratory distress? How will you suspect it?
For respiratory, if patient has respiratory distress, then patient will have trouble regarding any strenuous activity or any light activity, and patient will be easily fatigued, and there will
And
be increased
any
respiratory
signs?
rate, and there will be signs of dyspnea and tachypnea will be there, and along with intercostal suctioning might also be there.
And nasal flaring may also be there.
Nasal filling also.
Okay, you move on with your examination.
On airway examination, patient had myelopathy grade 1. Mouth opening was more than equal to 3 fingers.
How did you say that
Neck
this
mobility-
patient has a myelopathy grade 1? Why did you say so?
Because this patient had the facial pillars, the uvula, the soft palate and hard palate, all the 4 parameters were visible clearly.
Okay. Then other airway, what did you find?
Neck mobility was adequate. Thyromental distance were more than equal to 6.5 centimeter. Dentures were normal. There was no presence of any loose teeth. And on oral examination, there were bilateral palatine tonsil being congested and enlarged, which was Brodsky stage 3.
What do you mean by this Brodsky stage 3? What does it mean?
There is a scoring for tonsillar hypertrophy, that is Brodsky staging. There are 4 staging basically, stage 1, 2, 3, and 4. Stage 1 is less than 25.
No, what stage 3, what does it mean?
Stage 3 means it is between, it is covering the oropharynx of 50 to 75%.
Okay. Now, did you look at any comments from the ENT surgeon regarding the mouth, throat, and the nasal examination? Did you go
Yes,
through the
sir.
notes?
Yes,
Was
sir.
there
I
any
went to-
significant? Yeah. What did you
Yes,
find?
sir. I went through the notes, and on the they did the examination of the for the patency of the nares, and they commented that they did anterior and posterior mirror rhinoscopy and showed that there was no presence of any adenoid hypertrophy.
Okay. They didn't do any nasal endoscopy, did they?
No, sir.
Okay. Okay, move on.
When it comes to systemic examination, cardiovascular system, respiratory system, and central nervous systems were within normal.
In cardiovascular system, what did you examine?
In cardiovascular system, sir, we put the stethoscope over the 4 points of cardiac auscultatory areas, and we found no murmur or any pathological changes. And also we checked the pulse volume, which was normal, and there was no increase in heart rate.
There was also thrill. There was no thrill, no, in this patient.
No, sir, there was not.
Okay. Okay. Move on.
When I come to the investigations, hemoglobin was 14 gram per deciliter. Total leukocyte count was 7800. Differential count showed neutrophil was 41%, lymphocyte was 54%, platelet count was 2.38 lakhs, prothrombin count was 15, and INR was 1.08.
Why did you do a prothrombin time in this patient?
Although this patient didn't have any history of bleeding, but we advised it because the tonsillar area is highly vascular, and there is very much increased chances of post-tonsillectomy bleed along with intra-bleed. If intra-bleeding happens, then the surgical field might be obscured and it will increase the operative time.
But this patient did not have any history of bleeding previously.
No,
Did he? He didn't have.
No, sir.
Okay. And another thing I think you missed out is the serological tests. So what are the serological tests generally performed in the patients?
In our institution, we usually advise the HIV 1 and 2 along with HBsAg and anti-HCV.
Okay. So these were also normal.
Yes.
Okay. So you can summarize your case.
Uh, Now, I like to summarize my case. A 8-year-old male patient from Kharagpur, West Bengal, presented to the ENT OPD with complaints of throat pain and difficulty in swallowing of food since 12 days, along with reduced food intake since 10 days. He was apparently well 12 days back, then he developed throat pain, which was gradually progressive, was aggravated on taking cold liquids, and relieved on taking medication and warm fluids. It was associated with pain on swallowing of any solid food particles, leading to reduced food intake. He had history of sore throat, 8 episodes in last year, which was associated with fever. There was history of recurrent upper respiratory infection from childhood, although there was no such any recent onset with similar episodes. There was no history of snoring and mouth breathing or any sleep disturbances. On general examination, there was enlarged tender upper cervical lymph nodes. Systemic examination revealed no abnormalities. On airway examination, patient had myelopathy grade 1. Oral examination revealed bilateral palatine tonsils being congested and enlarged. No other abnormalities were detected on airway examination. All investigations were within normal limits. So my provisional diagnosis is a 8-year-old male child of ASA grade 2 presenting with chronic tonsillitis with upper cervical lymphadenopathy posted for bilateral tonsillectomy.
Yes, there was a suggestion in the chat box that you should have done also the blood group. Yes, that is acceptable. Thank you for the suggestion, please. Now, we proceed with the case directly. Okay, so we ask you the questions, now you answer. I think you can put off your slide presentation because we have done so this. It's okay, Dr. Nishant, no?
Yes, sir. Yes, sir.
Yes. Okay. So, Dr. Trisha, it was a nice presentation. And now, what are the indications of tonsillectomy?
Indications of tonsillectomy are various reasons, like if the patient has airway obstruction, dysphagia, or upper obstructive sleep apnea, recurrent tonsillitis not responding to medical therapy. If the excess of tonsillectomy is happening more than 5 times per year, or excess of symptoms throughout the year, and excess of severe sore throat, which is disabling. Along with that, there can be.
Okay, no, there are so many things you have told. Okay, what are the contraindications where you will not do tonsillectomy?
If there is any presence of active infection, if the patient has any coagulopathy or coagulative disorder, along with if the patient has any uncorrected partial or complete cleft palate, that will lead to velopharyngeal insufficiency.
Okay. Can you tell me any situation where tonsil is not the pathology, but tonsillectomy is done as a procedure? Okay. So the answer is vulopharyngeoplasty, glossopharyngeal, neurectomy, these sort of things. Okay. Now, what are you? How do you actually pre-medicate this patient?
The basis of pre-medication is to ease out the separation anxiety of this patient and to provide Silocox for the decrease in the secretion. Now, to ease out the separation anxiety, I will try to provide good rapport with the patient. Along with that, I will ask for parental presence and pouncing the parents beforehand that what procedures is going to happen to this patient. I will ask the patient.
No, I asked you about
mother.
what pre-medication. I asked you what pre-medication are you going to do?
Yes, sir. For ease out the separation anxiety, I'll give sedatives like oral syrups, we can give triclophos syrup, oral midazolam syrup.
No,
We can go
you-
for internet.
Please, Dr. Trisha, what you can give, but what are you going to give? Are you going to give sedatives to this patient?
Yes, sir. I'll give sedatives to this patient because the patient didn't have any feature of obstructive sleep apnea, so it can be safely given to this patient. For this
What will you
patient, I'll
choose?
give oral. I'll choose oral midazolam syrup at
What is the dose of?
0.5 to 1 mg per kg.
Okay, and how will you give it? Will you give it directly, or there is some preparation of it?
There is commercial syrups are available for midazolam. I'll give it with the help of a spoon.
Okay. Any other medication are you going to give?
I'll give anti-sialogogues. For this patient, I'll give glycopyrrolate to this patient.
Any other drug you want to give?
And these patients are very prone to postoperative sore throat. To prevent this, I'll give gargling of ketamine to this patient.
Okay. Now, I would just like to want you to point out what are the main problems of this operation.
Main problem of the operation is first of all, the patient can be uncooperative to the IV cannulation, separation anxiety, shared airway with the ENT surgeons. So there is high chance of tube displacement and obstruction of the tube. And there can be increased intraoperative hemorrhage along with increased postoperative pain, and there can be increased adverse respiratory events.
Okay, and postoperative sore throat also.
Yes.
Yes. Will you give antibiotic prophylaxis to this patient?
In our institution, antibiotic prophylaxis is routinely given to decrease the postoperative secondary infections and to decrease the postoperative halitosis and fever. Usually, OMS is given in our institution.
Okay. Say suppose if this patient is having problems during the separation from the parents. So how are you going to manage it? Manage the
First of all,
situation?
at the pre-anesthetic checkup, I will have good rapport with the patient. After that, I will ask the patient's mother or the parents to stay at the duty until the induction is happened. I will ask the patient's mother how the procedure is going to be done and hold the mask gently over the child's face until induction. I will use the scented mask for this patient.
And what induction agent are you going to use in that situation?
In this patient, induction agent will be inhalation, preferably sevoflurane.
And if the patient was not combative, then what would have been your choice, IV or inhalation?
Sir, can you please repeat the question?
Yeah, if the patient was not combative, if there was no problem regarding the parental separation, then would you have chosen inhalation or would have gone for IV induction?
Then I for the as the sevoflurane has pleasant smell, I will go for inhalation alone. Sir.
So your choice is inhalation. And then what are you going to give for intubation? What muscle relaxant are you going to give?
In our institution, atracurum is available. I will use atracurum for this patient.
In our institution, we have saxamethonium. You won't prefer saxamethonium?
No, sir, I wouldn't. It wouldn't be my first choice because this patient will have, as the patient is 8 years old, male child, so there can be occult neuromuscular disease. So, if I
Not your
give
first
scoline to
choice.
this patient, so patient might.
Okay. Now, you will maintain with also, what is your maintenance? How will you maintain anesthesia?
For this, sir, I will maintain with inhalation agent only. So,
So if you had maintained with propofol, what is the benefit of propofol in this patient?
benefit of propofol is it will decrease the chances of postoperative nausea vomiting in this patient.
And there is some problem regarding just after waking up with sevoflurane. What happens? then?
Yes, sir. In this patient, if sevoflurane is used, there is increased chances of emergence irritation in this patient.
Will it be there with if you are using propofol?
No, sir. The chances will be reduced.
Okay. So if you are using propofol, can you say what is the infusion rate of propofol?
The infusion rate of propofol will be 1 to 2 mg per kg per minute. Per minute.
1 to 2 mg per kg
Per minute
minute
per
per.
hour. Hour, sir.
And if the surgeon asks for using adrenaline, which they generally infiltrate, so how much adrenaline are you going to allow? What is the problem of giving adrenaline in these patients?
In our institution, adrenaline is routinely given in the tonsillar fossa. The maximum allowable dose is 5 microgram per kg. And if we give adrenaline to this area, and if halothane is used, then there can be catecholamine induced cardiac dysrhythmias can happen.
But this is not very common with sevoflurane, isn't it?
No, sir.
Okay. Now, what is your analgesia plan for this patient intraoperatively?
I will provide preemptive analgesia also, and for the intraoperative analgesia, I will give small doses of fentanyl along with paracetamol infusion.
So preemptive, what did you choose? What did you give?
For the preemptive analgesia, sir, I use the non-opioid analgesia, that is paracetamol infusion only, sir.
Dexamethasone you also told, I suppose.
Yes, sir. Dexamethasone I've given for PLV profile.
And also for analgesia. What is the dose of dexamethasone you would give to this child?
0.05 mg per kg, sir.
Okay, and what tube are you going to use? And what is the site of insertion? Where did you place the tube?
Sir, for this patient, as there is no signs of adenoid hypertrophy, I can go for nasal intubation in this patient. And the size of the tube will be based on Pine's formula, that is 8 by 4 plus 3.5. For this patient, age is 8, so it will be 5.5 internal diameter.
So what tube? Any special type of tube is used? Will you use?
For this patient, I will use the microcroft tube.
Will you go for array tubes or flexometallic tubes in this patient? This is the airway operation.
Yes, sir, I can go for array tube, but
No, what are you going to choose? You have all the options. What are you going to choose?
in our institution, the most common available tube is the normal PVC tube. So I will use that only and fix it in the midline.
The question was something else. Question was, if you had the option, what would you have chosen?
If I had the option of array tube, then I would chosen the array tube.
Array tubes. So North Pole or South Pole?
This will be South Pole, sir.
Okay, South. And where will you fix it?
I will base the multiple point fixation. I will fix it in the midline, sir.
Okay. And when will you, what are the times you are going to check for the tube? You are going to check the tubes at what times?
After the tube insertion has been done under direct laryngoscopy, Then I will check for the 5-point auscultation in this patient to check where the tube has been inserted. And after that, after the Rose position has been confirmed, then I will also again check for the placement of the tube, because at the repositioning there can be high chance of tube displacement.
So what is the main problem with using RA tubes?
In RA tubes, sir, the insertion technique is quite difficult compared to the PVC tube, and the suctioning might be difficult in RA tube.
Now, what monitors are you going to attach to this patient?
I will attach standard ASA2 monitors like ECG, QFB, along with NIBT, that is non-invasive beam monitoring, saturation with plethysmography, and I will also attach the precordial stethoscope and intidal CO2 monitoring for this patient.
So, suppose, what is your viewpoint about using supraglottic airway in these patients?
In this patient, in some centers, the supraglottic airway is used, that is the flexible element, which is wide reinforced and narrower tube for the specially built for the shared airway. And the role of supraglottic airway is that if the plan A says that according to DAS guidelines, that is the endotracheal intubation, then we can go for plan B, that is supraglottic airway devices. And during extubation also, we can use the laryngeal mask exchange.
So during extubation, laryngeal mask for what? What is the purpose of using laryngeal mask in these patients during extubation?
So can you please repeat the question? Connection is not
The question, okay. So what is the purpose of using the supraglottic airway during extubation in these patients?
If the during extubation, if we see that the patient is at risk algorithm, then we can use the supraglottic airway devices, that is the laryngeal mask exchange, along with the airway exchange catheter.
So can these patients be at risk for difficult extubation?
This patient doesn't have any such.
No, at the time of extubation, can it be a situation like that which may have developed?
Patient might go into the
No, there may be
laryngospasm or
surgical.
airway edema.
Yes, airway edema and surgical manipulation. Two A's are there. So definitely there can be difficult extubation in these patients. Okay. Now we move on to post-operative extubation. Extubation, you are going to give, how are you going to extubate this patient? Awake or deep plane?
In this patient, I will prefer the awake extubation.
Awake extubation. And why not deep plane?
Because, sir, as airway manipulation has happened, and there can be increased coughing and bucking in this patient, and that will lead to increased bleeding, and there can be aspiration postoperatively. So I will ensure that all the airway protective reflexes have returned, and then only I'll extubate this patient.
Okay. So what are the common problems that you think are going to happen just immediately post-operative?
There can be primary hemorrhage in this patient. Along with that, there can be emergence agitation due to sevoflurane. There can be postoperative stridor, laryngospasm, bronchospasm, and postoperative sore throat in this patient.
So perioperative respiratory adverse events can be there. So any particular position you are going to put the patient after operation?
Yes, sir. In this patient, I'll prefer the tonsillar position, which is basically in recovery position in lateral side, along with slight head down tilt.
Okay. And By which lateral position are you going to choose? Right or left lateral?
Left lateral, sir.
Why? This is not a pregnant patient, then why? Easier to intubate in that position. Okay. Now, what is the most dreaded complication you think of in these patients in post-operative
The
period?
most dreaded complication is post-tonsillectomy bleeding.
Bleeding. And how are you going to suspect the bleed? The patient is bleeding.
This patient might have the blood thin sputum along with coffee ground emesis. There can be signs of hypovolemia like tachycardia, tachypnea, decreased capillary refill time, decreased urine output, along with MEWS score less than 3.
What is MEWS score?
So this is modified early warning score. The parameters are
And what are the
basically
parameters here? What are the parameters?
parameters are, sir, respiratory rate, pulse rate, systolic blood pressure, along with temperature and CNS in terms of FPU scale.
Okay. Now you find the patient is bleeding intraorally. Now what are you going to do?
First, I will reassure the patient and then assess the state of hypovolemia. I will tell the intake surgeon to give OT intimation as an emergency procedure, and I will, if the re-exposition is necessary, then I will go for rapid sequence intubation with preferred pressure.
And another channel you would do, na? Whiteboard cannulation.
Yes, sir. And I will also prepare the smaller tube size, 0.5 to 1 size smaller, two similar tubes along with two whiteboard suction cannulas.
Okay. So this patient means after this relook operation, then when are you going to actually let the patient leave the post anesthesia care unit? Now the situation has changed. Now patient is hypovolemic, and then another question is when will you order for blood? You have initially cross-checked for blood. So now are you going to order for blood in this patient?
For this, I have to calculate the maximum allowable blood loss as the patient's age is 8 years. So I will consider the estimated blood volume of 70 ml per kg. And after calculation, I have found out that the maximum allowable blood loss is 990 ml. If it crosses that, then I will order the PAC cell volume. PAC cell blood.
RBC, okay. And what is your transfusion trigger you have for your maximum allowable blood loss you have counted for this patient?
For hemoglobin, sir, it will be 7, and for hematocrit, it will be 20 to 25, sir.
If it is 20, it is something, it is 25, it is different, isn't it? 7 or 8
Yes.
differs. Yeah. And now the last question I was asking you is when are you going to allow the patient to leave the PACU?
For this, sir, I will use the LDAT score for this patient. If it's more than equal to 9, then I will consider PACU discharge and H2 admission.
Why do you want to have a HDU booking in this patient?
Because, sir, this patient was already hypovolemic and there was increased blood loss in this patient. So I have to assess at least one organ system in this patient, that is the cardiovascular system. So I will go for HDU admission in this patient.
Okay. And last question is, what are the recent advances in tonsillectomy?
So recent advances in the is basically in the surgical technique in tonsillectomy, that is transoral radical tonsillectomy and laser surgery.
Robotic surgery?
Yes, sir.
Transfer or
Transfer
direct?
robotic surgery.
Yes, yes. Okay. Okay, I think we are just in time, Dr. Nishant. Or shall I continue with the questioning?
Yes, sir. I mean, there are a few questions which Dr. Derlin might want to address. And
Okay.
Yes, sir.
Well-
There has been so many questions here, sir. So the first
Okay.
question was to repeat the answer which you have given earlier, sir, that the indication for tonsillectomy other than tonsillitis.
Okay, the answer is actually uvulopharyngoplasty, okay, for OSA patients. Then there is glossopharyngeal nerve neurectomy, and also this stapedectomy. Means, that these are the, I think, 3 indications which are there.
Yes, sir. The next question is whether the succinyl choline is contraindicated in children less than 8 years.
I think Dr. Trisha has given the answer that because there may be occult myopathy in this patient, so better to avoid succinylcholine unless there is a difficult airway situation, suspected difficult airway situation, where the benefit outweighs the risk.
And another question is whether we can try for a nasal intubation, and if so, which RA tube is preferred?
Which RA tube? If you are going for a nasal route, then obviously the North Pole, N for N, will be there. If you are going through the oral, then the South Polar tube is chosen. But you have to check, I think Dr. Trisha has missed this point, you have to check the patency of the nares, which nair is more patent, and then you actually prepare the nose and then insert it. But I think the preferred would be for flexometallic tube. What is your viewpoint, Dr. Nishant, regarding this, or Dr. Madam Kurdi? Flexometallic tube.
Regarding the choice of RA tube.
Yes.
Yes, RA tube and
Yes.
both flexometallic. Between this, what are you going to choose if you have the option?
Yes, I think I would also go in for a RA tube only, more
Okay,
than a
so-
flexometallic. Yeah.
So North Polar RA tube. Okay. Any other questions we have?
The other question is what is the importance of mouth gag, like that
Short
the
gag.
mouth gag
Mouth gag.
while
Okay,
inserting the
boils
mouth gag.
Okay,
What all
Dr.
precautions?
Trisha, Dr. Trisha, can you highlight the points regarding the boils with this mouth gag?
For the placement of the mouth gag, the anesthetic consideration will be requirement of muscle relaxation in this patient.
And care regarding the tube also, because the tube may
Yes,
be
sir, and
compressed.
their thinking of the tube can happen, and also in postoperative period, there can be stomatitis can happen due to prolonged opening of the mouth with the boil's mouth gag.
And there is a, for this positioning, rose position, how are you going to position it? What things are you going to require?
For
Dr.
the
Trisha.
For the rose position, sir, I will use pillow behind the shoulder blades along with the head ring over the below the oxygen.
And the basic idea of this is what? Apart from good
Hyperextension,
visual, prevent hyperextension. And another important thing is that the larynx,
opening of the mouth.
yeah, the opening is the mouth is the lowermost part, so it drains out rather than goes to the stomach. Yes. Any other questions?
What is the significance of rose position for anesthesia?
So we have discussed it. So for anesthesia, it is mainly for the surgeon. We work for the surgeons. So the comfort of the surgeon is the #1 primary thing. So that is why we had done it. And our anesthetic considerations are to prevent hyperextension, compression of the tube, and these are the 2 main things which we should be careful.
And so next one question is what are the merits and demerits of deep extubation?
Dr. Trisha, would you like to answer? Demerits of this thing, deep extubation.
the merits of this deep extubation is as the patient there is increased chances of postoperative hemorrhage. So if the patient happens to be coughing or bucking, then the loosened clots might open and there can be aspiration of the blood and secretion in the trachea. So if the airway reflexes are not present, then if we do deep plane extubation, then there can be aspiration transfer.
I think there is another question which came, that what is the local anesthesia if you're giving? How are you going to give the local anesthesia? This came in the chat box.
Yes, so for local infiltration, for each tonsil there will be 3 points of injection. First one is the upper pole, lower pole, and the anterior pillar.
Okay. What are the structures in the lower pole that you should be afraid of?
So first of all is the glossopharyngeal nerve, then tonsillar branch of the facial artery that can be there. So high chances of intra-arterial injection is there if we go for
internal carotid artery, lingual artery, these are also quite there. So it is quite vascular. You should be particularly careful regarding the lower. Any other questions?
One more
I think
question.
yeah.
So one more question. What will you do if the patient goes into post-op stridor due to blood trickling?
Okay. Dr. Trisha, you're going to answer post-op stridor.
Yes, if the patient has postoperative stridor, then it if the patient is postoperative stridor, it can resolve spontaneously. We can wait, but if this stridor is very severe, then we have to give nebulization of adrenaline, or we can give nebulization of salbutamol in this patient. And if needed, if it doesn't respond to the medical therapy, then we have to re-intubate this patient.
One more question.
Yes.
What if during intubation, if the tonsil starts bleeding and then you cannot intubate? So what you will do? Did you hear?
Yes.
What if during, hello Trisha?
Yes, ma'am. Can you please repeat that?
What if during intubation, the huge tonsil starts bleeding and you cannot intubate? What will you do in that scenario?
First of all, if the tonsil starts bleeding, then I will use the suction catheter to clear out the remaining blood in the oral cavity. And if it's still not visible and the tube insertion is difficult, then flare A has failed. Then according to DAS guidelines, I will go for plan B, that is the supraglottic airway devices.
Actually, if the patient tonsil is bleeding, even then, I think the best option would be to stop and wake up the surgery, wake up the patient. Stop the surgery, wake up the patient. So I think that is the best option at that point of time, if the bleeding cannot be controlled that way. But if the surgeon insists or there is a bleeding continues, then obviously the thing is we have to now put in a tube, and the most experienced will call for help, and the most experienced person would do a sort of intubation at that time. And obviously the first things, these are the, if we cannot intubate, then we move on to supraglottic, and lastly we have the picothyrotomy. So that is a situation which we should try to avoid by actually waking up the patient and postponing the operation.
Yes, sir. We have a very senior faculty, Dr. Madhuri Kodi ma'am, and she's the one who was asking about this patient with the bleeding. Ma'am, you have something to add?
Yeah, I think I agree with Suman sir's plan, what to do. But Dr. Trisha, you have given the patient atracurium. So in such a case, to wake up the patient would be a bit difficult. So in this situation, would you go back to saying that you would give scoline to the patient to intubate for intubation?
Ma'am,
Just a possibility I'm asking you.
And as I've examined the patient, there is very less chances of situation of CICS situation, that is can intubate, can ventilate situation.
Why not? Why not? You have given atracurium to the patient and the huge tonsils, sometimes there are very huge tonsils, kissing tonsils sort of, and they start bleeding heavily. And the more you suck, the more they start bleeding. In such a case, what will you do? Like, infected tonsils also can go on bleeding. So huge tonsils will bleed. So that time, what will you do? Like, and you have given atracurium to the patient. Probably if you had given a short, yeah.
I should, yes, if this situation happens, then I would have considered succinylcholine in this patient.
But
No,
you have
you have
already
given
given
that.
atracurium.
Now you
Yeah,
go
I
into
have,
the process. You start with, like I have told, you try laryngoscopy, intubation. If you fail in plan B, then you have the plan C.
diagnosed ventilation also.
Then plan D, like that. The DAS guidelines. Obviously, you have to follow it.
Okay, right.
And good muscle relaxation is very important for supraglottic, for mask ventilation, and even for cricothyroid. Keep that in mind. So the level of muscle relaxation should not wane. I think we should go for the second case because there will be shortage of time.
Yes, sir. I think almost all questions have been answered. So I think we can move on to the next sessions, next presentation.
And before we move to the next speaker, Dr. Trisha, you've been very confident and very well done. Sir, it is not easy for young children to opt and present these cases in front of the whole country. So big congratulations to Trisha and Anushri both.
Thank you, sir.
Dr. Anushri?
Yes. So do you accept kind of start now? Sir?
Dr. Anushri, I am Dr. Devashish Bhatt. Shall
Yes, sir.
she start her presentation?
Yes, sir. Please start.
Anushri, start.
Yes, sir. Very good evening to my respected teacher. Today I am going to present the case of postponed contracture neck. The patient was a 65 years old male who was a factory worker by profession, and he reported to our outpatient department on 17th April 2023 with burn injury and was examined by the anesthesia department on 28th April 2023. His chief complaint comprised of disfigurement of the lower portion of the face, neck region, part of the chest and back.
Dr. Anushri, your voice is not clear. Please adjust your microphone.
Sir, I am audible now?
Yes, you are audible, and please go slowly.
Yes, sir. His chief complaint comprised of disfigurement of the lower portion of the face, neck region, part of the chest and back, and also parts of the hand since 6 months. He also complained restricted mouth opening along with tightness in the chest. His history of present illness revealed that the patient was apparently well 6 months back when he developed burn injury owing to cylinder explosion in the factory. Burns spread over the lower part of the face, the neck region, upper part of the chest, and back, and parts of the hand. The total body surface area detected burn summed up to approximately 32%. And later on, he developed contracture over neck, leading to flexion deformity and scars over the chest and back.
Dr. Anushri,
yes, sir.
I would like to know the history of his present illness, whether he has gone in hysterectomy or any debridement or any airway management during her initial treatment phase. Airway management, intubation, or tracheostomy. Are these present in this case?
So, sir, while taking this, we are taking separately the treatment history which he had received initially, but he didn't undergo any kind of intubation, nor there was any kind of system scar present, sir.
Now continue.
There was, however, no significant history regarding difficulty in swallowing or breathing. Neither there was any change in voice, nor there was any instances of bleeding from the oral cavity in this particular patient.
Did the patient
This was
suffer
a
from
fact.
any weight loss? Did the patient suffer for any weight loss during his treatment period?
No, sir. Our patient hasn't suffered from weight loss. We have taken his initial weight in the pre-anesthetic check and have asked about his previous history about any weight loss or his previous weight. But he said that there was no weight loss. But he complained to some extent that there was loss of minute muscle.
Okay. And what was the initial extent of his burn at the initial period? Now it is you are expressing it is at 32%, the burn contracture area. What was his initial burn area, burn surface area? Did you
Sir,
ask that?
yes, sir. Actually, when he sustained a burn injury, it involved not only the lower part of the face, neck, upper part of the chest and back, but also to some extent the upper part of the lung. During the development of the contracture, the hands weren't affected. It is mainly the lower part of the face. The scar actually spanned from the lower lip to the upper part of the chest. Sir. Some scars were there in the back as well. The arms were totally spared.
Okay, continue.
Okay, sir. In the history of past illness, there was no relevant history regarding diabetes mellitus or any other chronic disease, but he had undergone an open left-sided hernioplasty surgery 7 years back under regional anesthesia technique. His personal history reveals that he was a non-smoker, non-alcoholic, having no specific addiction, but he had his appetite and sleep reduced to some extent. We also have allergic history, which showed that he had no allergy to any specific drugs or food, and his blood and bowel habits were quite normal, and he was non-vegetarian by diet. His family history showed that there was no history of hypertension, diabetes mellitus, or comorbidity in his first degree relatives. Neither there was any history of tuberculosis among the family members, nor the neighbors. In the treatment history, we saw that the patient was hypertensive in nature. So he was receiving amlodipine 5 milligram once daily dosage since 5 years. Because of the burn injury he sustained, he got admitted to the burn ward of the hospital 6 months ago, where he got treated initially for 20 days, was discharged upon recovery. General
In the
examination
personal
details. Yes,
history, and the patient sleeps in supine position during at the night, or during when he wants to sleep, or he has to take some other position.
sir, while taking history, we asked about this, and the patient said that he prefers to sleep in the lateral position because he has a flexion deformity of the neck. So once sleeping in the supine position, it finds it difficult. And if he has to sit in the supine position, number of pillows have to be supported below the knee. So it prefers to sleep in the lateral position, sir.
Okay, fine.
On general examination, we found out, sir, the patient was quite alert, conscious, and cooperative, with a weight around 56 kgs. The height was 5 foot 6 inches, and the calculated BMI came around 20.1. Patient, however, had pallor of mild degree, but there was no icterus or cyanosis. Blood pressure measurement in the left arm in the sitting position showed it was around 136 by 80 millimeter of Hg. Pulse came around 80 per minute, which was regular. Normal volume, no delay, no special character was there. The respiratory rate was around 14 per minute with no signs of distress. Saturation we recorded, the baseline came around 98%. The veins in the upper limbs were quite prominent. Next, we move to the airway examination. The nasal openings were adequate enough, and the burn didn't encircle the nasal area. The mouth opening was, however, restricted to only admitted 1.5 fingers of the patient, that is roughly around 1.5 to 2 centimeters. We faced quite a difficulty in checking the modified Mullen-Petri score. This was because of the restricted mouth opening and the flexion deformity of the neck. So whatever we were able to examine, we graded it close to grade 2. Another problem we faced was in the measurement of the thyromental and sternomental resistance. Because heart tissue was actually spanning the lower part of the chin chest, we couldn't actually palpate thyroid, cricoid, and other important landmarks. So thyromental and sternomental distance couldn't be assessed. Upper lip height Khan's test showed it to be around grade 3. Temporomandibular joint examination revealed that we cannot insinuate one finger in front of the trigger, whereas the neck was split to around 15 degrees. Tension was possible in like up to 85 to 80 to 85 degrees, and the patient was restricted in all directions. Patient was unable to protrude his mandible. However, there was no loose teeth.
How did you examine the modified molybdenum?
So
How did
we
you
faced difficulty while examining for Mallampatti. But what we did was to make the patient sit in the path with head in the neutral position, and the eye level of I was examining. So our eye level was at the level of the mouth opening. Patient was asked to open the mouth adequately with no phonation. Then we tried to examine the degree of visualization of the facial pillar, uvula, the soft palate, and the hard palate. And the degree, actually, what we saw was that we were just able to see the palate to some extent because of the limited mouth opening and because of the flexion deformity. So we went for grade 4, sir.
Okay. And what is the difference between the original molempati and the modified molempati? Can you tell?
So for the Samsonian modification, grade 4 has been added.
Oh. And how did you perform the upper lip bite test? And what is the significance of it?
So first of all, we ask the patient to be in the sitting position and explain him the entire procedure he is going to do. He is asked to bite upper lip with the teeth of the lower lip. If he is able to bite upper lip above the vermilion border, which is taken as grade 1, below the vermilion border, grade 2, and if he is not able to bite at all, it is taken as grade 3, which happens in our patients.
What is the significance? When you expect that will be a difficult intubation, at what grade of upper lip bite test?
And it comes around grade 3, that is, he is unable to bite. We take it as a case of difficult laryngoscopy and intubation, grade 3 of upper lip bite contrast.
Okay. Continue.
Yes, sir. Under local examination, we start with inspection, which shows flexion deformity over neck is present. 5 strands are seen running from the neck to the upper chest. Scars are present over the anterior aspect of the chest, and to some extent, the back is also affected. On palpation, the scar tissue showed no tenderness, neither there was any ulcer or sinuses present. The sternum notch was to some extent palpable. We faced problem regarding the palpation of thyroid, cricoid, cricothyroid membrane, and trachea, which were not palpable over the scar tissue. Next, in the systemic examination, under cardiovascular examination, we evaluated S1, S2, and there was no murmur present. Under respiratory system, we are able to hear equal bilateral breath sounds with no adventitious sounds. Central nervous system, we examined the patient and found out that he was quite alert, conscious, and cooperative with adequate power in all 4 limbs. Back examination showed that there was the scar in the upper part of the back, but no other abnormalities were detected. On the investigation, sir, we went for complete blood count. On the head, it turned out to be 9.1, with a total leukocyte count of 7,000 per cubic millimeter. Platelet count came around 234,000 per cubic millimeter. Once our patient was not diabetic in nature, we preferred to go for random blood glucose estimation, which came around 110 milligrams per deciliter. Serum electrolyte, it went for sodium, which showed 132 milli-equivalent per liter. Potassium came up 4.8 milli-equivalent per liter. We also went for serum creatinine, 0.8 milligram percentage, and blood urea nitrogen came around 35 milligram percentage. The electrocardiographic study showed low voltage QRS complexes with no other abnormality. We went with two types of X-ray. One is the chest X-ray PA view. We showed that the bilateral lung fields are quite clear without any deviation of the trachea or any other lesion. We also went for lateral neck X-ray to determine the presence of flexion deformity of the neck to make sure of the flexion deformity of the neck. So these are two imaging we performed.
Okay. Before you go to summary, I want to ask you something. Can you describe the nature of scar tissue that is present in the anterior part of the neck? Whether there is a band formation, broad scar, or linear scar, which type of scar it is?
Sir, it was actually a band scar which was traversing from the non-involved lower lip to the upper part of the chest. By band scar, we refer to the fact that it covers less than 50% of the surface of the neck. The scar on palpation revealed no tenderness, neither there was any ulcer or sinus present on the scar. Because identification of the different landmarks became very difficult for us, the thyroid required precothyroid membrane.
Okay. And this patient has little bit mild anemia. What may be the cause of anemia, chronic anemia, in case of these burn patients?
So generally, after birth, it is seen that there is increased PC breakdown. If we consider the initial phase of management, there is administration of resuscitation room. So that can also bring about a situation of dilutional agitation. Apart from that, it is also seen that there is decreased erythropoiesis, coagulation abnormality, an ongoing infection sir, which predispose the burn patient to develop situation of mild moderate anemia.
And you have said that there are lots of burn tissue or scar formation over the anterior part of the chest. So what kind of respiratory anomaly, respiratory disorder you can expect in this? It might not be there, but what you can expect?
So because of the scar tissue which is present in the chest, it will have an external restrictive effect. So chest compliance will be affected. So I am expecting that if a lung disorder might develop, it would have been of a restrictive nature because of expensive.
Okay. And what about the renal function? Can the renal function be hampered in case of burn case? In case of acute burn, what type of renal function, renal disorder may happen? And in this type of post-burn contracture patient, what type of renal disorder can happen?
So in the very acute phase of burn, problem would happen that there is increased blood supply to the kidney. So kidney is actually suffering from renal perfusion. So there can be development of situations like acute tubular necrosis or renal failure. And in the later part, mark-proteinuria, hemopoteinuria-like condition also complicates the situation, putting the patient in a situation of renal failure.
And also sepsis. Sepsis is very great cause of renal failure.
Yes.
And whatever the why did you perform the electrolyte in this patient, electrolyte examination? What is the importance of electrolytes in this case?
Yes, sir. We went for sodium as well as potassium estimation, sir. So regarding the burn patient, the problem is that there is excessive tissue injury is there, and this causes increased permeability of the cell. So there is enhanced potassium influx, which predisposes the patient in a situation of hyperkalemia. Sir, after burn, it is seen that there is proliferation of abnormal isomers of nicotinicholinergic receptors, like gamma isomers, 7-alpha isomers, and their problem is that they have a prolonged spinning time, during which there is enhanced release of potassium from the cell. Altogether, a burn patient remains in a status of hyperkalemia when compared with a normal patient, and the patient can develop arrhythmia or cardiac arrest events.
What is the normal amount of potassium elevation in normal patients when you give successfully?
So when we are using depolarizing muscle relaxant insulin, normally it increases to increases by about 0.5 milliequivalent.
And what happens in case of this type of bond contracture patient?
So in burn contracture patient, already because of so much potassium intake, the swelling, their increase needs to be close to 1.3 milliliters per liter.
How long will we avoid, for which duration will you avoid sustenance swelling in this patient?
So the general consensus is to go for avoidance of swelling starting from 24 to 48 hours after birth till up to 2 years.
2 years. Or it can be less than that.
Dr. Debashish, I think there is a little bit of disturbance which is coming from. Are there two machines at your end? Or probably if you can see, there's some disturbance. And Anushka, could you be a little bit louder, please?
Sir.
Yeah, I'm sorry to disturb. Please.
Is it normal now?
Actually, when Dr. Anushka is speaking, there is some disturbing sound which is coming from your microphone.
Okay, then I shall mute that right at that time.
Once you can, yeah. Please go ahead.
So is it okay now? My voice level?
Yeah, better.
You can go-
Better, yeah. Please go ahead.
Dr. Onus, tell me, that this patient has only 30% burn. Can we use succinylcholine after 1 year?
Sir, generally, after 1 year, because of 30% body surface area burn, we can use succinylcholine choline to some extent, but it's preferable to wait till 2 years. We can use in some situations, in some journals, choline has been used after 1 year.
Okay. Now you can summarize your case.
Okay, sir. So the summary of my case is that 65-year-old male residing in Shalboni, factory worker by profession, hypertensive and non-diabetic by nature. He complained of disfigurement of lower part of the face, neck, upper part of the chest and back, following thermal burn injury that he sustained 6 months back because of explosion of cylinder. On examination, we saw the scarring extended from the lower lip to suprasternal region. Contracture encircles anterior portion of the neck with limited neck movement in all directions. Total body surface area affected by burn summed up to around 32%. Airway examination revealed that there was limited mouth opening, about 1.5 fingers, with a modified Mallampati score, close to grade 4, and an upper lip bite Khan test of grade 3. Systemic examination revealed no adequate abnormalities. So my provisional diagnosis is there's a case of post-burn contracture with anticipated difficult airway posted for post-burn contracture release and microstomia correction.
Okay, thank you. Now, can we classify your post-burn contracture and in what grade it belongs to?
So if we are following the UNAT classification of contracture grading, my contracture falls in grade 2. UNAT classification actually depends upon the anatomical location of the neck and the degree of flexion extension abnormality which exists. So there are actually 4 types of contracture, which first 3 anterior contractures. In type 1 contracture, it is a mild anterior contracture wherein flexion to the normal anatomical position is possible and extension is limited to some extent. And here, skin and subcutaneous tissue is mainly involved. In type 2 of the contracture, which happened in our case, it's a moderate anterior contracture, wherein flexion to the normal anatomical position is possible. The problem which is being faced is with extension. On attempted extension, there is pull of the non-involved lower lip. Herein also, skin and subcutaneous tissue is mainly involved. In type 3, it's called the severe anterior contracture, wherein the neck already remains in a flex position with the chin pointing close to the trunk. And the extension here is limited. Here, apart from the skin subcutaneous tissue, the strap muscles are also involved. The last, that's type 4, is posterior type of contracture, wherein the neck remains in the extended position with limited flexion, and here is skin as well as subcutaneous tissue is involved. Our patient falls in grade 2, which is a moderate anterior contracture.
And what is the importance of doing a lateral X-ray of neck?
We went to lateral neck X-ray, sir, to be sure about the flexion deformity, which we found on external examination.
Anything you can plan for the planning of your management, for airway management, you can get any information from the lateral X-ray of the neck.
Sir, on the basis of the degree of flexion deformity, we can plan whether a direct laryngoscopy would have been possible, or we would have to go for fiber optic or etc.
Actually, if the angle between the maxilla and the pharynx, the maxilopharyngeal axis angle is less than 90 degrees, then the placement of supraglottic air will be difficult. It will be dislodged. And also, if you go for a fiber optic bronchoscope, then the visualization of the laryngeal inlet will also be difficult. So these two are main things which are we look for when we look for the lateral X-ray. And also the tracheal, the diameter of the trachea, whether any distortion in the trachea, these are all visible. These are already visible. So this will help us to choose the right size of the tube. Okay.
Yes, sir.
This question now this patient has been posted for burn contracture release, and in the PSC, how will you assess the patient, and what is your anesthetic problems in this patient?
So, first I'm taking up the anesthetic problem in this patient. First and foremost, because of the flexion deformity and the limited mouth opening, I can assign the patient to be case of difficult airway. Followed by, so we have to have plan laid down for management of airway, along with the presence of a senior anesthesiologist. Second, sir, these patients after burn injury often is seen to suffer from malnourishment, anemia, as well as hypoproteinemia. So optimization of these aspects are also very much essential. Our patient didn't have any burn injury such that we couldn't go for IV access, but sometimes if the burn is obscuring the hands or the other sites, IV cannula placement might be an issue. Also, placement of the different probes of the monitors which we are going to do, sir, which we are going to use, like non-invasive cuff placement or for PP monitoring, or for going for pulse oximetry analysis. This placement of probes become difficult, and we might have to choose for IV invasive PP monitoring, or placement of the pulse oximeter probe at the ear lobules, at the nose or tongue, or in the placement of electrodes for ECG. We also faced here also actually we faced problems in placement of the electrodes, and then we had to go for needle electrodes placement. Apart from this, patients are hugely predisposed to the development of hypothermia because of evaporation and radiation. And blood loss, estimation of blood loss is essential in this case, sir. So keeping at least 1 unit of cross-match blood in hand is essential. Also, after burn, there is alteration of the pharmacodynamics and pharmacokinetics of several different agents, including the induction agents. So we have to alter the dose, have some idea regarding the duration of action. And because, as I've already mentioned, sir, there has been undue regulation of extrajunctional nicotinic cholinergic receptors of abnormal isomers. So our dose of non-depolarizing muscle relaxant, depolarizing muscle relaxant also gets altered.
Any abnormality in that non-depolarizing muscle relaxant, the response will be the same or something altered?
No, sir. Actually, it is seen that there is increased resistance to this stuff, so we have to use the higher dose to get the adequate onset time or duration of action.
And what about the analgesia?
So, from analgesia point of view, this patients, after having suffered from burn injury, suffers from neuropathic pain, allodynia, hyperalgesia-like condition. So, better if we go for multimodal analgesia technique. Here in our institution, actually, we chose to go for opioids in the form of fentanyl, and along with that, a paracetamol infusion was used. But we can also make use of non-steroidal anti-inflammatory drugs like traminophene, diclofenac, but our patient was 65 years age. So the chances of renal toxicity, and because it's a boy patient, we avoided the use of non-steroidal anti-inflammatory agents. And we can make use of peripheral nerve block as well, sir. And here I would like to point out, sir, that burn causes few psychological impacts on pain as well. So situations like cognitive behavioral therapy might also be helpful in this patient in pain management in the post-op area if we are speaking.
Okay. How will you assess the airway of this patient? Because airway management is the keystone of this patient. So keystone of the patient management. So how will you assess the airway? How will you assess the mask ventilation, difficulty in the mask ventilation, difficulty in the intubation, and difficulty in the placing of supraglottic airway?
So the way of us taking up the situation of difficult back mask ventilation, we can make use of different physical indices which indicate a difficult back mask ventilation, like presence of beard, obesity with a BMI of greater than 26 kilogram per meter square, then presence of abnormal teeth or edentulous patient, but presence of actually of teeth which is overriding of the maxillary teeth, uh, followed by if the patient is a snorer. So these are the indicators which show that it's a case of difficult back mask ventilation. For difficult laryngoscopic intubation, there are several physical indices and group indices. Some of the group indices being Bell-House criteria as well as Wilson scoring, sir. So with the help of them, we will.
What are the components of visual scoring? And what are the things we have to do for the visual scoring?
In total, there are 6 parameters in Wilson scoring, starting from weight in kg of the patient, then head and the extent of head and neck movement, which is expressed in angle. Then is the jaw movement, sir, which actually gives us the inter-incisor distance. Then the protrusion of the mandibular incisors beyond the maxillary incisor, presence of receding mandible, and presence of buck teeth.
Can you describe the Lemon classification?
Lemon is actually used for determination of a difficult airway for laryngoscopy and intubation. For L, we have to look for some external anatomical features which might detect difficult intubation and laryngoscopy, like presence of short neck, obesity, facial beard, facial trauma tumor, large tongue, arched palate, etc. Then, according to E, we are going for evaluation, sir, by the 3-3-2 rule, wherein if the patient is able to pass 3 fingers inside the mouth, we consider it to be an adequate oral opening for easy laryngoscopy and intubation. Another one is if the patient is able to place 3 fingers in between the floor of the mouth, that is the mandible, sir, and the upper and the hyoid bone, then it actually indicates adequate mandibular space for allowing the tongue to accommodate during laryngoscopy. And if the patient is able to accommodate 2 fingers in the floor of the mouth, that is the mandible, and the upper border of the thyroid cartilage, it indicates a normally placed larynx, and we can do away with the situation of high laryngeal position. Then is the Mallampati grading, sir. If grades 3 and 4 is there, we consider it to be a case, might be a case of difficult intubation and laryngoscopy. Then we have to assess whether any obstruction is present or not. And if at all obstruction is present, then which location? Above the glottis, at the glottis, or below the glottis? Or whether the obstruction is a fixed one, like a tumor, or the obstruction is a mobile one, like a epiglottis. And whether the obstruction is actually progressing in nature. And last but not the least, sir, we have to look for the movement of the neck, whether there is having any restriction of the neck. And normally in laryngoscopy, normal laryngoscopy, we try to have the slipping position. So flexion of 25 to 35 degree, extension of about 85 to 90 degree, and rotation of 70 to 75 degrees associated.
In this patient, do you think there will be a difficult mask ventilation? What are the points in favor of difficult mask ventilation in this patient?
Yes, sir. So in our particular patient, uh, I have considered in the pre-anesthetic checkup itself that it will be a case of difficult back mass ventilation because there were the burn area was actually obscuring the lower part of the face. So there were scars present. So I thought that it will be difficult for the mask to seal properly.
Can we put a supraglottic airway in this patient? And if you can, what type of supraglottic airway will you choose?
So generally in the burn patient, because in our patient particularly there was a limited mouth opening, sir, placement of supraglottic airway in our pre-anesthetic checkup we considered difficult. But if at all we would have gone for supraglottic airway device, second generation LMA would have been my choice because of the extra port which is present for preventing aspiration. And other supraglottic devices like the combi tube and LTS would have been utilized, sir, if situation arises.
Actually, combative or LTS in this limited mouth opening situation would be better because you can put it easily. Can you enumerate the difference between the combative and the LTS?
Sir, in the combi tube, we have the advantage of having both the esophageal as well as the laryngeal balloon. Sir, can you please repeat? I couldn't hear.
The difference between the combi tube and LTS, laryngeal tube suction.
So in the combi tube portion, we are having the advantage of securing the esophageal and laryngeal area. But in the case of LTS, sir, in this case, we have actually two tubes. In this LTS portion, we will have some problem regarding securing of from the esophageal aspect.
No, and actually not that. Actually, there is a LTS there is another port for suction. So in the combi tube, there is no way you can suction the laryngeal, peripharyngeal, and esophageal secretion. That is one advantage. And LTS has only one pilot, one inflation line. So with one inflation line, you can inflate both the balloons. And NTS is actually causes less trauma. Combi tube can cause if the esophagus is distorted, there is chemical burn, and then combi tube would not be ideal. It would be actually contraindicated. But LTS you can use. Okay.
Okay, sir.
Now, what is your plan of airway management in this case? How will you prepare the patient? What is your plan? Tell me what is your plan? First plan is an alternate plan, and how will you prepare the patient?
So my first plan for securing the airway is to go for fiber optic bronchoscope guided awake tracheal intubation. That's my plan A. And for if it fails, my plan B involves use of video laryngoscopy, but again going for awake tracheal intubation. From the preparation aspect, if we are going for fiber optic bronchoscopy guided awake tracheal intubation, first and foremost, I would like to adequately counsel the patient, sir, because we have to, then we can gain his cooperation, which is very essential during this proceeding. We will be choosing the nasal route. We will be making the patient understand what problems we are facing regarding his airway, what are the procedures or steps we are going to perform. So our patient will be more cooperative with us. Next, we come to the facts of we will apply decongestant for a better nasal for our nasal preparation. So vasoconstricting agents like oxymetazoline, xylometazoline, etc. was used. We actually use xylometazoline nasal drop, followed by desiccation or drying up of secretions. In our institution, we made use of injection glycopyrrolate 0.2 milligram IV for drying up of the antisilolog agent, because then the secretions won't blood the fiber optic bronchoscope and the dose of local anesthetic won't be diluted too. Next is the most important part, sir, that is the topicalization of the airway. In our institution, we went with lignocaine 10% spray, about 20 to 30 puffs, according to the DAS 88 guidelines. 20 to 30 puffs for 5 minutes at the base of the tongue, at the tonsillar pillar in the oropharynx. And each of the puffs actually consists of 10 milligram of the drug. These puffs were given during inspiration. Apart from that, we went for nebulization with 4% lignocaine and preparation of the nasal mucosa also with lignocaine. Apart from this technique, sir, we can also make use of gargle 4% lignocaine, which is a viscous solution, and atomizers also can be used. According to the GARS guideline, which we actually use later on while progressing with the fiber optic bronchoscope versus spray as you go technique, sir, wherein 2% of 2 ml lignocaine was sprayed just above the glottis, at glottis and below the glottis. We are spraying 3 times. So this is what we did for topicalization, and we totally avoided going for nerve block because we couldn't identify the landmarks, as the scar tissues were totally obscuring anterior part of the neck. Transtracheal, glossopharyngeal, or superior laryngeal blocks were not given. Next, we come to sedation. First and foremost, the doses should be very less as and when required. And for this purpose, we can make use of midazolam, like in the dose of 0.02 to 0.03 milligram per kg. Fentanyl like 1 to 2 microgram per kg, but we have to judiciously titrate the dose, avoid polypharmacy, and it's better to go for agents which have reversal agents. And
Can we
last of all is
use
Yes.
dexmedetomidine for sedation?
yes, sir. We can use dexmedetomidine in the dose of about 0.5 to 1 milligram per kg.
Now, if suppose you are trying for a awake nasal intubation, your first choice, why not oral route? Why the nasal route is preferred during awake intubation?
The patient acceptance in the nasal route is generally more. Secondly, the curvature of the nasal passage, it's similar to that of the endotracheal tube. It's easier to pass the endotracheal tube. More, this nasal passage remains in line with the laryngeal opening, so we can pass the endotracheal tube much easier. The patient cannot bite or chew the tube if we are passing through the nasal airway, and also the gas reflex is less stimulated.
Okay. Suppose you are not able to do the awake intubation. This is a failed awake bronchoscopy. Then what is your next plan?
Next, also, sir, we will try to go for awake intubation, but using video laryngoscope in this case.
What type of laryngoscope with 2 centimeter mouth opening will you choose?
Sir, actually, the video laryngoscope in our institution, we make use of vision, but also if indirect optical rigid laryngoscopes are present, like Bullard or fiber optic or ear track optical fibroscopes are present, we can.
Laryngoscope, but with our vision, it is not possible to intubate in this patient. Yes. Then what will be your, if you fail to do the fiber optic, then what is your next plan? If the in our institute we cannot do the rigid video laryngoscope, what we have? So what is your next plan?
So then I will try to insert supraglottic airway device, which is also very difficult in this case because of the mouth opening. So Combitube and LTS is available in our department. We would go for with them.
Can you ask the surgeon to release the scar tissue and under ketamine anesthesia, and then you
Yes,
can try it again, the laryngoscopy.
yes, sir. Using intravenous anesthetic agents like ketamine or earlier Timucin anesthesia technique was used. First, we asked the scar tissue to be removed by the to release the scar tissue by the surgeon, and thereafter applying postcard, we can again try to secure the airway. First, try to do direct laryngoscopy, and then afterwards we can follow the algorithms.
Can you do a blind nasal intubation in this case? There is a question. Nasal intubation, is it possible?
Because the burn injury has spanned the neck area, we considered that the larynx might not be in its normal position. To some extent, it might be deviated. And
It's expertise for to do that, and in our day it is actually very much limited because we are not used to do blind nasal intubation. If at all we have to do a blind nasal intubation, we need a flexitube endotracheal tube so that we can manipulate the tip of the tube, and we also need a ETCO2 monitor and attached to the end of the proximal end of the tube, so that by assessing the carbon dioxide level and also by hearing the breath sound, we can negotiate with the laryngeal opening, and also by adjusting the tip of the tube. There's a flexibility. And can you tell us something about the two-minute anesthesia?
This is actually a type of infiltration anesthesia where large volume of local anesthetic along with epinephrine is injected into the subcutaneous tissue involved by the scar. And then we wait for about 20 minutes and the scar tissue becomes soft and tumescent. And then the scar release happens, which is done by the surgeon. And then we can try to secure the airway. The mixture which we are actually using consists of 2% lignocaine 30 ml with epinephrine 1:1000, about 1 milligram, 1 milliliter of hyaluronate containing 1500 international units, and about 450 ml of ringer lactate solution. The total solution turns around 70 to 200 ml, and the local anesthetic dose in this case can go up to a very high dose, like about 35 milligram per kg. But the stimulation anesthesia has its own advantages too. Because we are using a dilute solution of local anesthetic along with a vasoconstricting agent like epinephrine, usually you do not face the problem of local anesthetic toxicity, but it can happen. It's one of the backlog of this procedure. And also epinephrine being diluted, the problems of tachycardia or hypertension is not faced. And also 18 hours or because the local anesthetic effect to some extent post-operative analgesia stays.
There is chance of air embolism and water intoxication also. There is large volume of water you are giving, so that can
Yes.
happen.
Yes.
Have you heard of retrograde intubation? And is it possible in this case?
So I have heard of retrograde intubation using bone pills, wherein we actually avoid the central tongue and the central portion of the airway, and we move towards the side. I think if we try, it might be possible in this case because limited mouth opening, we can make use of that bone pills.
But,
Retrograde.
but the anatomy of the anterior neck is distorted, so we have to make a retrograde intubation. We have to first pierce our picothyroid membrane and pass a epidural catheter over that, so that it will come out through the mouth. So if we cannot palpate the picothyroid membrane or delineate the picothyroid membrane, so it is not very easy because we cannot delineate the picothyroid membrane. So how can we puncture the picothyroid membrane and pass the catheter? Okay, so it will be difficult. I think that should not be tried. There are so many other options. We can go for other options also. Okay. Tell me, what are the intraoperative problems you may face?
In the intraoperative period, the blood loss and blood loss can be an issue in this case because we are going for contracture release as well as microstomia correction. So we have to be very cautious and go on with hemodynamic monitoring and also look at the urine output with the fluid we are providing at the same time so that we don't overhydrate the patient. Secondly, hypothermia is one of the issues, very important issues. So it's preferable that we cover the patient with warm clothing, at least 1 degree Celsius warm. And also, we can make use of inline post warmers and warm intravenous fluid as and when required, and maintain the temperature of the operation theater around 28 to 32 degrees Celsius. Also, sometimes difficulty in ventilating the patient might be there, sir, because in this case, the patient may be in a hypercatabolic stage with increased carbon dioxide accumulation. So in that case, we have to increase the minute ventilation to the respiratory rate.
Okay. Now, after the conclusion of the operation, how are we going to extubate the patient? Because always a difficult intubation has a difficult extubation. So how are you going to plan the extubation?
For planning of extubation, sir, first of all, presence of a senior anesthesiologist is expected, along with the entire difficult airway cart should be there with all the necessary items and the drugs to control a catastrophic situation. And if we are following GARD's guidelines of extubation, we have to plan, prepare, then proceed for extubation and go for post-procedural management as well. We first have to plan regarding after assessment of the patient's airway and the other risk factors which are present. Then we prepare the patient regarding the risk factors as well as specific features like his cardiovascular examination, neuromuscular examination, respiratory, as well as metabolic and temperature abnormalities, and also look at the location where we are going to extubate, the location, the skill assistance which is present, as well as the equipments we had, and we should continue monitoring at the same time. Then, if our patient can be extubated safely, then we preferably would go for awake extubation with consideration of alternative equipments like supraglottic airway device, airway exchange catheter, and even remifentanil technique, infusion technique as well. But if it's not a safe one, we can continue. We don't extubate the patient. We continue ventilation postoperative. We even consider tracheostomy situation. Extubation preferably can be done in HDU or ICU, etc. And in the post-procedure, post-extubation period, we also have to transfer the patient properly, give a proper handover, supplement oxygen properly, as well as inset for proper
Maybe we have
counseling and
to go for
documentation.
perioxygenation and extubate the patient over the airway exchange catheter. Okay, now we conclude
Yes,
this session. We expect some questions. Dr. Nishant, please continue with the question.
Yeah, sure. Dr. Derlin? And there are a few questions in the chat box.
Yes, sir. The first question is whether there is any relation with the percentage of burns area and the scoline used, and can you explain, sir? Percentage of burns area and the scoline used.
Yes, the burn area, some literature have come out.
Voice is not clear, sir. So your voice is not clear.
Some recent literature has come out. If the percentage of is less than 30%, then we can use succinyl choline after 180 days. But if it is more than 50%, then we should wait for at least 250 days. But for the safety of the patient, mostly you should wait using the succinyl choline for up to at least 1 year, and preferably up to 2 years if possible.
Yes, sir. The next question is about the classification of the types of contractures, and is there any relations with anesthesia? It has been explained before, so the student want to explain it again about the classification of the contracture, burns contracture, and its relation with anesthesia, or is there any importance with anesthesia?
Dr. Musri, will you like to repeat the question, repeat the answer?
Yes, sir. Especially if we are going for one classification of contracture, there are 4 types of contracture. Type 1, 2, 3 are basically mild, moderate, and severe anterior contracture, and the 4th one is a posterior contracture. The specification actually asked whether we are facing any difficulty in anesthetic management with the type of contracture actually. If we have the type 1 and type 4, we can go for intubation. In type 2, we'll consider it to somewhat difficult. We can go with fiber optic bronchoscopy, but in the type 3, which is the moderate type of anterior contracture, often there is requirement of release of the scar first under intravenous anesthetic agents like ketamine, and thereafter securing of the airway can be done.
Questions has been about blind nasal, retrograde, and tumescent anesthesia, which has been explained here. So, and another question is, can USG be used to make a cricothyroidectomy in this patient?
Definitely, if USG is available, we can assess the airway and go for a retrograde intubation with cricothyroid membrane puncture.
Yes, sir. With that, almost every question has been answered.
Yes, all questions have been answered. Dr. Muthu Kumar is actually one of the one who asked this question. I think he was asking about the percentage of burns and its relationship with the anesthesia. Dr. Muthu Kumar, if you can unmute yourself, is that what you wanted to ask?
Yes, sir. Sir, I am Dr. Mustafa. Sir, I was not able to hear your voice clearly, sir. Sorry to. What is the scoring? You told something about scoring 30%. If it is more than 30.
30 with one. Actually, it is a 30 with which actually causes the fibrosis.
Sir, I am not able to hear.
Okay, Muthu, then, what happens is during the first 48 hours after a major burn. Now, what is a major burn? Major burn is a full thickness burn involving more than 10% of the body surface area or a partial thickness burn of more than 25%, correct? So, in the first, so there is some, so in the first 48 hours, you can use because the risk of hyperkalemia is not that much. But after that, the risk of hyperkalemia increases because of the immature N-acetylcholine, those receptors that are formed. Okay, so no, actually, studies have been done on humans in which the acetylcholine receptor upregulation has been studied. But even even after 5% burns, there can be upregulation and hyperkalemia. So it is preferable to avoid scoline after 48 hours. And as sir said, 1 year definitely, probably 2 years. Sir, please correct me if I'm wrong.
That's absolutely right. Though there,
So your voice is not clear.
should wait. Preferably to wait.
Muthu Kumar, have we answered the question?
Sir, the voice was not clear. I just want to know why it is less than 180 days for scoring in certain 30% of burns, less than 30%. Sir, I'm not able to hear this. Voice is not clear, sir. I'm sorry.
The less the amount of burn tissue, the less amount of extrajunctional acetylcholine receptor. Can you hear?
Yeah, yes, sir. Yes, sir.
So
Okay.
if
If it is less than 30%, you can give it less than 6 months to 1 year. Am I right, sir?
But it is that has recently come out. It is preferably wait
Wait for
up
2 years.
to 1 year.
1 year. Okay, sir. Thank you, sir.
Yeah.
Thank you.
Come down to 1.
And we have some very eminent faculty also with us. We have Dr. Sarbari Madam, Sarbari Swaika Ma'am. Okay, I think she was here.
Network on.
Are there any other questions? Dr. Madhuri, ma'am. Yes, please, Dr. Madhuri.
Yeah, I think sir has covered most of the questions related to the post-burns neck contracture. So the questions can be asked related to acute burns also, where the fluid resuscitation and nutritional management can be asked. So Anushri, can you tell us about the fluid resuscitation in a case of acute burns?
Yes, ma'am. If dealing with patient with fluid burn, we can make use of different formulas for fluid resuscitation. Most commonly make use of Parkland formula,
Okay.
which gives us initial 24 hours plan.
Yeah, that's all right. So just I wanted to tell you that these questions can be asked. And secondly, the Atlanto, there is a fixed, more commonly it will be a fixed flexion deformity. So how did you look for the neck extension in your case?
While we were examining the patient in the pre-anesthetic checkup room, we asked the patient to look up without raising his eyebrow, which he was not able to do completely. His neck extension was around 85 to 90 degrees at the most. So,
so because it was extension and vision is limited to the horizontal plane, then it comes to 85 to 95 degrees. Do you know what is that warning sign of Delican? Have you heard of it? It's a very simple sign, the warning sign of Delican.
Anushri, it is your
It
final.
is
It is your
related
final.
to it is related to this neck extension only.
You answer it, you are passed. Your degree is given today.
Okay. Okay, I'll tell you. So what you do is you place your index finger of each hand, one underneath the chin and one underneath the inferior occipital prominence of the patients, with the head in his head in the neutral position, not your head. And then you ask the patient to fully extend the head on his neck. So if the finger under the chin appears to be higher than the other finger, then definitely there will not be difficulty with intubation. But if the level of both fingers, especially the chin finger, remains lower than the other, then there is likely to be increased difficulty. So like that, there are many tests and many signs and all. For example, how will you predict that there is going to be difficulty in passing a supraglottic airway device? Any method? Any system, scoring system? For example, in this patient, is it going to be easy to pass a supraglottic airway device?
No, ma'am. There is restricted mouth opening, ma'am, because my patient has mouth opening of only 1.5 finger.
Okay.
We can make those. One of the parameters is restricted mouth opening. Then we are looking for obstruction of the upper airway, ma'am. If there is obstruction of the upper airway by burns or by tumors even involving the airway. Also, ma'am, if we are looking for disruption the upper airway, that also will cause a difficulty in placement of supraglottic airway device. And last but not the least, ma'am, we will be looking for presence of staples.
Yes. And will there be any difficulty in securing doing a surgical airway?
Yes, ma'am. In particular our patient, it was difficult because we couldn't identify the landmark. The different parameters which we can make use of are first of all presence of bleeding abnormalities, either inherent coagulation abnormalities or the patient is on anticoagulant drugs. Our patient, if the patient is agitated,
yes,
there is
very good. Yes. So if there is a bleeding tendency, or if there is patient is very agitated and uncooperative, or if there is scarring on the neck, as in your case, or if there is a growth or a vascular abnormality in the region of the surgical airway, then this is known as a bang criteria. You are going to have a difficulty in securing creating a surgical airway. Okay. Yeah.
Anushri, shall I ask you a gold medal question? You will get a gold medal today. If suppose in this case, post one contracture, the situation after giving, suppose if somebody asking scolin, avoided something like anything, or even rocuronium, you given the muscle relaxant and the situation cannot intubate, cannot ventilate. So how will you go in this case? If you answer this, you will receive a gold medal today.
The front of the neck access is not an option for me in this particular case. I will, in usual day-to-day life, what we do is to try to backmark the patient and bring back to the normal plane.
Good. Rather, if you think the patient has to be operated, there are chances when Dr. Suman or Dr. Debashish will be with you, only then you proceed further. In such cases, it's sometimes what happens, it's a skill of the plastic surgeon also there. You keep on giving local to the contracted area, keep on incising that particular area till you are sure that you are able to open the mouth. That is just giving adequate local, not with just taking about this is some situation where a surgeon can easily help you out in certain situations. Suppose the patient you can still ventilate. That situation has come now. You have taken the patient back to the spontaneous, but patient is still under. You give local to the particular area. You slowly start releasing the contracture. At certain degree, if you are able to release the contracture, you will be able to use the supraglottic airway devices, or you'll be able to intubate the patient. That is one scenario, but that is advisable only in the presence of senior people. Okay, that is one scenario. But it's a very difficult such cases. They give you a tricky part whenever you are appearing for examination, and even in the examination, don't give any such answers which are not practical, not feasible. They will deduct marks. They will not help you scoring. They will deduct the marks. Fine. Good, good, very good. Good performance. Dr. Suman and Dr. Devashish have prepared both of you very well. I think that you are going to shine in your examination. So a small medal you have earned today, and in the final you will be earning good gold medals also. I hope hereby Dr. Madhuri and Dr. Nishant will be your examiner. So you will definitely get a gold medal.
Actually, last year when she was in the first year itself, she got the second prize in the quiz, the state.
Okay, great, great. That's why it's looking from the and appearing on the screen in front of the national crowd is a sign of a good confidence. I think these classes, they are instilling the confidence in all the students who are appearing on this screen. And once they appear on this screen, I think they are very well confident of performing well in the examination also. Not these, their counterparts, their other contemporaries also in the classes. They will be having full confidence that our colleagues have appeared, so we can also appear. Isn't it?
Thank you, sir, for this opportunity from a peripheral hospital, medical college, which was previously a district hospital.
Sir, examinations, whether in a peripheral or in a top institution, it's the same examination. Students' mentality remains almost same. It's hardly 19-21 ka fark hota hai. But the mentality remains same. The thing is that the confidence, once they get on during these long case and short case discussion, and when they see this classes on the YouTube later on, and it gives them a good idea how to answer these things, because every external and every internal, they have a different way of asking the questions. So majority of the questions are covered in this type of classes.
Thank you, sir, for the opportunity.
Anybody wants to give suggestions? Any suggestion or any question left? Anybody else? Okay, nobody. So actually, this was the 99th class today, and the next class is a 100th class, a century of classes. And to the house, I will just declare I will be taking that class, and it will be a very surprise class, something not related to the theory or practical, something more different than that. And I think that has to be seen by maximum people from the country. It will be 100 class. We will be celebrating. And it's a celebration of all the students and all the dedicated teachers who have appeared on this one ISA website for with full preparations and dedicating their time, giving good feedbacks and good tips to the students. I think it's a wonderful way of interaction. Definitely the feedbacks are required from still, because there is always a scope of improvement. Even if you become perfect, there is always a scope of improvement. So these classes will be going on, and in the future, Dr. Madhuri and Dr. Nishant will also be there. Sometime I may be missing these classes. So Dr. Madhuri and Dr. Nishant will be conducting these classes, and all our facilitators, like our young faculty, like Dr. Darlene and all other people, they will be helping us to take this step forward. So I'm really thankful to both Dr. Suman Chattopadhyay sir and Dr. Devashish sir. You have spared excellent time today, a very quality time, especially taking a hard work in preparing your students. And both Anushri and Trisha, they have done good. Their question and answer, their confidence is good, and their, the manner was good. Just like a good student. You are like good students, so you answered well. And always as good as, Dr. Madhuri, Dr. Nishant, they are always there to help me out. And this time Dr. Darlene was there. So it was nice interacting with all, and big thank you to everyone. So we will be meeting at 6:30 p.m. in the next class. Till then, I think it's time to say goodbye. And